Hi, ladies and gentlemen. Welcome back to BGS Clinics. In this clinical class, I will discuss the principles of investigation after having arrived at a clinical diagnosis or at least a provisional clinical impression. Investigations, especially in a surgical case, may be classified as pathological, imaging, endoscopic, and system specific. Various tests which fall under the category of pathological investigations are so-called lab investigations, that is physical, chemical, and bacteriological examination of body fluids such as urine, blood, cerebrospinal fluid, ascitic fluid, pleural fluid, pus, etc. Cytological examination, meaning microscopic examination of cells obtained most commonly by aspirating through a fine needle and sometimes by other means such as gently scraping a lesion with a brush or centrifugation of fluids, and histological examination of tissue obtained by taking a small representative piece of a lesion called biopsy. In addition, there are some more pathological investigations, just to mention a few: PCR testing, immunohistochemistry, etc. Imaging investigations are plain X-ray, contrast X-ray, ultrasound scan, CT scan, MRI scan, PET scan, etc. Endoscopy means visualization of the mucosa and lumen of gastrointestinal, urinary, or genital tract using various kinds of scopes. Imaging and endoscopy, although basically diagnostic, can be extended for therapeutic intervention as well, thus avoiding the need of surgery in some cases. For example, on arteriography, if a block is found in an artery, then the procedure may be extended to angioplasty with or without stenting to open up the artery. Then you have system-specific investigations such as electrocardiography, electroencephalography, pulmonary function testing, etc. If nothing positive comes back out of these investigations, but if disabling symptoms continue, then you may have to take up the patient for exploration, either formal open surgical or minimally invasive, usually extended to therapeutic intervention as well at the same time. To establish the diagnosis of disorders affecting superficial tissues and external organs, investigation is often not required. Superficial means superficial to deep fascia. This is a cross-sectional figure. This is skin, this is subcutaneous tissue, this is deep fascia, this is muscle, and this is bone. The anatomical structures superficial to deep fascia are said to be superficial, and the criterion is applicable to various pathologies as well. For example, sebaceous cyst, superficial dermoid cyst, subcutaneous lipoma, neurofibroma, fibroadenoma in the breast of adolescent girls, etc. There are some pathologies which may involve the deep plane as well, but even then, diagnostic investigation may not be required, as in case of boil, abscess, carbuncle, pilonidal sinus, anal fissure, external hernias, etc. In all these cases, clinical diagnosis can be relied upon with confidence to proceed with treatment. Nevertheless, if there is no certainty in the diagnosis, or if malignancy is considered as one of the differentials, then you need to investigate. In majority of surgical disorders affecting the deeper tissues or internal organs, you need usually one or occasionally more than one investigation to confirm the clinically made diagnosis or establish a diagnosis which could not be made clinically. This is called the key investigation. Additional supporting investigations may be requested later, which serve one or more of the following purposes. They may strengthen the diagnosis suggested by the result of the key investigation. They may help to find out the cause of the disease, and they may help to estimate the extent of structural and functional destruction produced by the pathology. Okay, now this in clinical jargon is called the severity of the disease in terms of a direct threat to life or the degree of suffering and likely development of a disability, either short term, medium term, or permanent. In cases of cancer, the additional supporting investigations performed to determine the extent of spread of the disease are called staging investigations. The selection of treatment option depends on the stage of the cancer. Let us see a few examples of the so-called key investigation. The key investigation for esophagitis, peptic ulcer, or cancer of the esophagus or stomach is upper GI endoscopy. For gallstone disease, it is ultrasound scan. For pancreatic and hepatic tumor, it is CT or MRI scan. For small intestinal disease, it is barium follow-through. For colonic cancer, it is either colonoscopy or barium enema. Colonoscopy and barium enema have their own indications, pros and cons, but they are considered complementary to each other rather than mutually exclusive. Apart from the purpose of coming to diagnosis, we may also need to investigate a case to determine the feasibility of implementing and assessing the risk associated with the treatment option that is selected. Risk means the probability of developing complications. And you may have to request investigations for the purpose of research, including writing a thesis for masters. Investigations for pre-op assessment may be classified as the so-called routine and special. They are often set as a protocol in an institute. These are the so-called routine investigations. Full blood count, or also called complete blood count, urine routine and microscopic, blood sugar postprandial or blood sugar fasting and postprandial. If you are requesting blood sugar as a screening tool in a patient who is not known to be diabetic, then postprandial level is enough. But if you are requesting in a known diabetic, then it is better to get both fasting and postprandial. Blood urea nitrogen, serum creatinine, serum electrolytes, liver function tests, ECG, and X-ray chest. Please take a note, however. All the investigations listed here are not to be carried out in every patient. It is useful to think these investigations as mandatory, discretionary, or unnecessary in terms of the type of operation and the performance status of the patient. For example, in a patient below 40 years of age without any symptoms suggesting cardiac and pulmonary disorder, there is no need to request an ECG and X-ray chest. In a young fit patient who has to undergo excision of a small lump or bump under local anesthesia and who does not have any comorbidity, practically no investigation is necessary. Well, these statements may sound bold to those who practice in cities and are dealing with affording class of patients. But in low resource settings, please do not burden especially non-affording patients with the investigations which are not indicated. Basically, the principle of investigation is to ensure that adequate information is obtained before patient goes for surgery, but not at the expense of physical and financial torture to the patient. And these are the examples of some special investigations. X-ray of the thoracic inlet in a case of thyroid enlargement, pulmonary function tests and arterial blood gas analysis, coagulation screen, cardiac function tests, etc. Before requesting any investigation, you must have a knowledge of the following. What exactly do you mean by invasive? An invasive investigation or a procedure is one, the complication of which can be life-threatening. By this criterion, fine needle aspiration for cytology is a non-invasive investigation. The 25 gauge needle is so fine that even if it hits a blood vessel, oozing of blood will almost immediately stop soon after the needle is withdrawn, unless maybe if the patient is suffering from a bleeding disorder. What about gastrointestinal endoscopy? Is it invasive or non-invasive? Well, it is invasive because a potential complication such as perforation of, say, the esophagus or colon is indeed life-threatening. You must know the exact purpose of requesting an investigation with the information that you expect to find out of it. Please do not request any investigation casually. Here are a couple of examples of prerequisite. You should get a coagulation screen before investigation like PTC. PTC stands for percutaneous transhepatic cholangiography. Another example. Get serum creatinine level before any contrast study is performed in which an iodinated contrast medium is injected, which can have a deleterious effect on the kidney function. For example, intravenous urography, contrast enhanced CT scan, etc. If some medicine is going to be injected during an investigation, for example, an iodinated contrast medium, and if the patient is known to have any allergy related comorbidity like, for example, bronchial asthma, then you need to take two precautions. First, inject full dose of the medicine only after assessing the result of test dose carefully. And second, consider a prophylactic injection of a steroid like, say, injection hydrocortisone before the investigative procedure begins. Give clear instructions to be observed by the patient before and after an investigation, such as, for example, any specific medicine to be taken or omitted, whether patient needs to fast, how long, if patient is supposed to drink water, how much and from what time before ultrasound scan of the pelvis begins. If patient needs to take complete bed rest after the investigation, such as arteriography for example, then how long, and so on. Keep the patient informed about the potential sequelae and complications and their symptoms. You must know the cost of the investigation that you are requesting. You should see that it is cost effective. Now let us see the philosophy of selection of investigation. Do you really need to investigate in the first place? If so, how to select the most appropriate one out of many that may be available? Sensible selection of investigation is of great importance. There are two approaches in practice. First is to request a battery of investigations based on patient's symptoms in the hope that something will turn up. A battery of investigations means the whole list of investigations that are available on the menu card. This does not require application of mind. The second approach is specific or selective. The first approach is incorrect. The specific or selective approach is more logical. It is less expensive and less distressful to the patient. But appropriate selection depends on critical clinical evaluation, and that's the real problem, as that's what people don't want to or can't do. There is a tendency to take shortcuts by skipping detailed history taking and examination and instead relying blindly on investigation. And that is the root cause of many problems faced by clinicians. Request an investigation only when there is a reasonable chance that it will affect the management. Select the most appropriate investigation keeping in mind the following points. It should give relevant information most easily. For example, for diagnosing gallbladder stones, ultrasound scan is better than CT scan, and it should be cost effective. Now a tip specifically for the exam going students. In practical clinical viva exam, after submitting your clinical diagnosis, if the question of how to investigate arises, then talk about the key investigation first, followed by additional supporting investigations. So that's it. All the golden takeaways from my clinical classes need a reinforcement, and for that you need to keep presenting cases. Presenting cases is the key to achieve mastery in any branch of clinical medicine. Thanks for watching. Make sure to watch the videos in a sequence in the playlist Clinical Classes.